Hi, everyone, and welcome to week 6. This week, we're going to be talking about conception and contraception and abortion, and then conception, pregnancy, and childbirth. Some of the items this week are your Learn Smart chapters 11 and 12, choosing a contraception method wiki. There's an abortion assignment, which is related to no easy decision, stages of childbirth assignment, your chapters 11 and 12 quiz, of course, your discussion board, and then lastly, your issue paper rough draft. In the no easy decision, this is the assignment related to abortion. But the purpose of this assignment is to really think about the purpose of legalized abortion and to discuss the functions of abortion. And so you're going to analyze your own opinion um, and experience regarding this assignment. Please be respectful that everyone has different life experiences that have shaped their opinion. And what you're going to do is imagine you are a Supreme Court justice. Congress has just passed an amendment making it illegal to have an abortion for any reason. As a Supreme Court justice, you have been given a special privilege. The justices are able to grant one woman the last safe legal abortion before the legislation becomes law. Below is the only information you have given about each woman who is seeking the last abortion. Your task is to decide which women from the list below will be granted the last abortion. In your response, discuss why you chose that woman to be granted the last abortion. That's the first part. And then the second part is to think about the process of making that decision. Was it difficult for you to make your decision? How did you base your decision? What characteristics were you looking for in terms of which women you would grant the last abortion? So that is your task. The task is to tell your class which women you are granting the last abortion, why you chose that woman, and then I want you to consider the reflection piece. So how did you come up with that decision? Was it difficult to come up with that decision? The second assignment is stages of childbirth. And so in this assignment, you have a couple options how you want to present your information. You can create a short PowerPoint, you can create a cartoon, you can create a graphic organizer, or you can write a short essay. Regardless of which option you choose to present your information, your product, there's a typo, should contain the 3 stages of labor, the physiological changes that occur during each stage, and the length of each stage, and also the psychological changes for each stage. So what is going on mentally within mom. Let me end this really quick because I just wanted to talk about the rough draft quickly. So here is the assignment for your rough draft. Let's see if I can make this a little larger. And so what the purpose of this assignment is. So first you're going to write your rough draft, and it should be at least 3 pages long, double spaced, of course, Times New Roman, not including the cover page or reference page, right? So 3 pages of written text. And then after you write your rough draft, you are going to use this rubric and go through your paper. Is your paper 3 pages long? Yes or no? And then you're giving yourself points. You would actually type in the points. The main idea in the paper, is it easy, recognizable? Is it stated? Is it effectively stated? Yes or no? And give yourself points. Evidence in paper and citations. Do you find the paper contains enough textual evidence to support your claim? This includes areas in the document that are supported by references. So using citations, effectively formatting citations is the next one. So just using citations, yes or no, provide yourself points. Does your paper contain proper citations? Using documentation and use the APA style of referencing, yes or no? Do you have at least 4 references from peer-reviewed journals? Yes or no? And then the points you give yourself. And then, of course, any spelling or grammar mistakes. And then you will add up your total points here. The second part is completing the second half. So you're going to read through your entire paper. Highlight your main idea in green. Look for evidence in the paper that's supported by references. So you're going to underline those areas in your paper that have citations. make sure you are using APA. And if you're not sure, you can click on this link here for examples on how to write an APA. Then you're going to check all in-text references against the example list provided. Make sure you highlight those that are cited improperly in yellow so you know to go back and correct those. And then lastly, are there any sentences that need to be cited, meaning that you have stated some fact that's not your own, but you have no reference? Those you're going to highlight in blue, just so you know to go back and include references later on. As you read through the paper, of course, correct any spelling and grammar errors. And then lastly, after completing this worksheet, what are 3 things you will do to make this paper better? And you will list 3 things here. When you are finished with all of this, you can either copy this sheet here and paste it as your cover page for your rough draft, or you can submit 2 separate documents. But I just want to make it clear that this sheet here is part of what you're submitting for the assignment. Okay, and then of course you have your McGraw-Hill assignments. So this week we're learning about contraception and abortion. So some of the things to consider are the risk and responsibility in terms of getting contraception. Nearly half of all pregnancies each year in the US are unintended pregnancies, meaning they occur when they weren't supposed to, they weren't wanted, they weren't actively trying to get pregnant. Of unintended pregnancies, about 4 in 10 are terminated by abortion. Over the period of a year, sexually active couples who do not use contraception have about an 85% chance of becoming pregnant. That's pretty high. And contraception is the deliberate prevention of conception or impregnation by any various drugs, techniques, or devices. So it's preventing pregnancy. When we look at access to contraception, reproductive health care reflects a deep commitment to supporting the family. There's been some significant and necessary strides in the Title X Family Planning Program and Affordable Care Act, which both provide overlapping services. And this is to ensure that people have access to affordable contraception. Of course, there's been some religious and moral objections to some provisions in this act, but currently there are many options to receiving birth control that are covered by insurance. Now, this idea of reproductive justice is a concept that links reproductive rights with social justice. And some of the things to consider in terms of getting contraception are a person's ability to have and raise children or not, and then questions of equal access and opportunity to contraception. And so there are many ways and methods of contraception. So again, contraception is deliberate prevention of conception or impregnation by any drug, technique, or device. And there's a variety of methods. There are barrier methods, which is a physical barrier, just like it sounds, that is placed between the egg and the sperm. Spermicides, which kill the sperm before it gets to the egg. Hormonal methods, which inhibit the release of the oocyte, which is the female egg. Intrauterine devices, which prevent pregnancy from fertilizing the egg, the sperm from fertilizing the egg. So when you think about choosing a method of contraception, there are many factors to consider. First, what kind of preferences do you and your partner have, or any biases? Do you understand the advantages and disadvantages of each type? How convenient and easy is it to use? Does this method protect against STIs, including HIV, or is it only preventing pregnancy? What are the effects on menses, which is menstruation? Is it important that your partner be included in this choice, or is this something that you just want to work on yourself? Think about other influences that may affect your decision. Cost, how comfortable are you using the technique? Are you comfortable placing a ring in your vagina? Are you uncomfortable doing that? Are you good at taking a pill every day? Are you not good at taking a pill every day? So there are many questions to consider when deciding on an option that's optimal for you and or your partner. Knowledge and familiarity are also strong determinants of contraceptive use. So the more you know about different types of contraception, the more likely you will use them. And technology has really expanded on how women can track their periods and locate and access contraception options, accept reminders, but it really shouldn't replace professional advice. So always speak to your doctor in terms, or your nurse practitioner in terms of options for contraception. And realize that, of course, that there is contraceptive failure. Um, and this is a measure of a woman's probability of becoming pregnant during her use of a method. And there are two rates that are usually given when looking at contraceptive failure rates. One, oh, sorry, let me just bring this back really quick. There. One is the perfect use rate. Now, this is if you follow directions exactly. In a perfect world, here are the rates, and these are just estimated rates and what they should be. Then you have the second one, which is typical use, and this is the real rates. So what they do is they gave 100 couples a particular method to use, and then after a year, they measure how many of them got pregnant. And this is more accurate as it takes into account human failure, forgetting, and things like that, misusing it. So I just wanted to show you here of a table, and this is both perfect use and typical use rates. So generally, the ones that are the lowest oopsies are ones that you have little control over. So in implants, once it's in, you don't have to worry about it. Vasectomy, male sterilization, IUDs for women, tubal female sterilization. So you can see here the perfect use and typical use are very close in their rates, and they're very low. And then we have injectables. These are shots, progestin only, given every 3 months or so. Then we have the pill, and here we have 9. And what that means is that 9 women out of 100 got pregnant after 1 year. Diaphragm, we have 12. So 12 women out of 100 got pregnant after a year of use. And then the sponge, excuse me, there are 2 numbers given. The one is for women who have not given birth before, and the second for women who have given birth. So as you can see here, a sponge is more efficacious for women who have not given birth before. All right, then of course we have abstinence withdrawal. So abstinence, as I'm sure you've learned, is abstaining from sex. It's 100% effective, and it's the oldest and most reliable birth control. The second one is withdrawal. It's also called coitus interruptus. Coitus is sex, and then interruptus is interrupting sex. It's a traditional method in which the man completely removes his penis from the vagina, away from the external genitalia of the female partner before he ejaculates. So he ejaculates outside of the female's body. It's practiced all over the world, but it has a really relatively high failure rate. And that is because for men, before they ejaculate, they have pre-ejaculate. This is a substance that comes out of the penis before ejaculation occurs. And mainly it's to help lubricate the passage of sperm before they come. It's also to provide a basic substance, and basic, I mean the opposite of acid. So a basic substance to coat the urethra so that the sperm will not die on their way out of the body. But of course, in the pre-ejaculate is also sperm, and you only need 1 sperm to get pregnant. So even in pre-ejaculate, sperm are present, and that can result in a pregnancy. Okay, so now we have hormonal methods. This is the use of hormones to prevent pregnancy. Oral contraceptives are called the pill. They're a series of pills, and there are different combinations. It can contain estrogen and progesterone, different percentages of each, but really the purpose is to regulate egg production and the menstrual cycle. It's the most widely used reversible contraception in the US, and it suppresses ovulation 90 to 95% of the time. So if an egg is not coming out, then an egg cannot be fertilized and pregnancy will not occur. In most states, it must be prescribed by a physician or a clinic. It's considered the most effective method when used correctly, but not effective when taken inconsistently. There's also a birth control shot known as Depo-Provera. It's an injection of the hormone progestin, and it's used to prevent pregnancy for 13 weeks. It can lead to irregular bleeding and the cessation of periods, meaning the period will stop. But it really should not be considered a long-term form of contraception. Then you have the birth control patch, and this is a thin beige plastic transdermal reversible method. And it's a small little patch that is placed generally on the upper buttocks, and it releases synthetic estrogen and progestin, meaning man-made estrogen and progestin, and it protects pregnancy for about 1 month. And there's different types of patches. Some you put on once a week, some you put on every 3 weeks. Then you have the vaginal ring, which is the Nuva ring or birth control ring. It's a small flexible ring. It's inserted high in the vagina once every 28 days. And then you would take it out, menstruation would occur, and then you do a new one and put it in. There are also birth control implants, and these are called Nexplanon, and these are thin, flexible plastic rods about the size of a matchstick. They're inserted under the skin of the upper arm, and it can protect against pregnancy for up to 4 years. So here's just what a Nuva ring looks like. It's the vaginal ring. You can see it's thin, it's flexible. You insert it in the vagina, and it goes pretty high in the vagina, so it rests against the cervix or uterus. Now we have barrier methods, and these are designed to keep the sperm and egg from meeting in the first place. So you have your condom, a thin, soft, flexible sheath of latex. It could be plastic or lambskin. Lambskin is the least effective because the pores in lambskin are big enough so that the HIV virus can easily pass through those. But it fits over the penis to help prevent semen from being transmitted. So both latex and plastic condoms protect against STDs and, of course, pregnancy. Generally, women are more likely to contract an STI because the penis is inside her vagina. The vagina is a mucous membrane, so things pass easily from external to internal in the body. It's not like skin, which is a barrier. And so it's important that both male and females protect themselves from STIs. And then there is a term called selving. This is when a man secretly removes his condom during sex despite agreeing to wear one. There's also a female condom, which is the same idea as a condom, but this is loose fitting. It's polyurethane, has a diaphragm-like ring at one end, and then the other end sits outside of the vagina. It's designed to line the inner walls of the vagina and protect the woman against sperm. I don't think they're as comfortable as a condom would be, but they are very effective. And it also takes some practice using, and they're a little more expensive compared to a condom. But as you can see here, you would insert the inner ring so it sits against the cervix, and then the outer ring sits outside of the body. Some other barrier methods are diaphragm, birth control sponge, and cervical cap. So a diaphragm is a dome shape that's a flexible rim, and it sits against the cervix, so it prevents any sperm from entering the cervix and uterus. The birth control sponge works the same way, except it's more spongy. It's about 2 inches in diameter, and you would fill it with spermicide, and so that's the substance that kills the sperm. As you saw earlier, birth control sponges work better for women who have never had babies. For women who have had babies, they're not as effective. And then you have the cervical cap, which is like a diaphragm, except it's smaller and it's more hard shaped. Again, it's a device that's inserted into the vagina, and it sits against the cervix, so no sperm will enter the cervix, and it could be worn for up to 48 hours. So spermicide is a substance that is toxic to sperm, and Anaxol 9 is the most commonly used spermicide in products in the US. And there's different varieties of forms of Anaxol 9. It could be foam, film, cream, jelly, and suppository, but it is most effective when it's combined with a barrier method, but it can be used alone as well. Then you have a whole different class called IUDs, and there are really two types. There are ones that contain hormones, and then there are ones that do not contain hormones. But these are long acting, they're reversible, and it must be inserted by a doctor into the uterus. So as I said, it emits either copper, if it's made of copper, that's all you need, or there's one that contains the hormone progestin, both of which are hostile to sperm. All types are extremely effective and can remain in place for 3 to 6 years. They can also help reduce menstrual bleeding and cramping. And so here is what the device would look like. So here you have a couple different ones. The ones in the top right is the copper one. So you can see the copper is on the device. And then the other ones show that it is has hormones. But again, it's placed in the uterus. Again, this has to be by a doctor, but it's an office visit. You can see some short strings hanging out. They will hang into the vagina, but they will not come out of the body. And then, so then you have these that are called long-acting reversible contraception. And these are highly protective against pregnancy. They can last for several years. They're easier to use, so that includes the IUD that we just saw, and also the birth control implant. They're 20 times more effective than pills, the patch, or the ring. Um, and the American Congress of Obstetricians and Gynecologists are urging obstetricians and gynecologists to educate patients about long-acting reversible contraception, just because they are so easy to use and it's sort of like set it and forget it for a few years. Then you have fertility awareness-based models where this is a natural family planning where a woman would chart her menstrual cycle to track ovulation and then make sure not to engage in sex on or around ovulation. Requires a lot of motivation and self-control. And there are a couple of different methods you can use with that. I'll talk about that in a minute. So there is the calendar or rhythm method, which is when you find a woman's peak fertile times and safer days for sex from her longest and shortest menstrual cycles. There's the basal body temperature method, which uses slight changes in temperature, so taking your temperature, to determine a woman's ovulation cycle. However, the temperature change is a half a degree to 1 degree. So you need a really good method for taking the temperature. You need a really good thermometer. And then lastly is the cervical mucus method, which is you can determine a woman's stage in the menstrual cycle from the appearance and character of the mucus secretions of the cervix. And then, of course, you have sterilization, which is a surgical intervention that makes the reproductive organs incapable of producing or delivering viable gametes, which is sperm or cells. It's the sex cells. Sterilization is the most common method amongst married couples in the US. Male sterilization is simpler, safer, and cheaper. But in the US, nearly twice as many couples choose female sterilization compared to male sterilization. But regardless of which method you choose, all of these are meant to be permanent. So for female sterilization, there are a couple of methods. You have tubal ligation, which was formerly known as tying the tubes. Um, you have laparoscopy, which is a viewing lens is inserted in through a small incision, and then another instrument is used to close the fallopian tubes, usually by electrocatheterization or burning of the tubes. Essure is a brand. It's a non-incisional permanent system that uses small devices to block the fallopian tubes. So an Essure would go through the vagina all the way up into the fallopian tubes. They put a little metal, a spring. It almost looks like the spring that are in pens into each of the fallopian tubes. And then scar tissue forms around those, effectively blocking the eggs from coming through. I would caution you against using Essure. There has been some research to suggest that it actually can cause some damage. So just make sure you talk to your doctor if that's an option, what the research says in terms of safety. And then sterilization for men, of course, are vasectomy, which is a permanent birth control. The vas deferens is severed, which prevents sperm from entering the vas deferens, mixing with the pre-ejaculate fluid to form semen. Takes about a half an hour. Recuperation is just a few days. The physician will make a small incision or two to lift, tie, cut, and often cauterize each vas deferens. There's also a no incision method, and this is like one puncture is made to reach both tubes. They're 99.9% effective. Sexual enjoyment is not diminished, but if you're still worried about getting STIs, condoms will still need to be used. And then there's emergency contraception. So no birth control is 100% effective. And of course, there could be oopsies or you have sex and the next day someone's kind of worried. So that's just where emergency contraception comes in, or the morning after pill. It can be taken within 120 hours after intercourse. And what it does is it inhibits ovulation, so it stops the egg from leaving the ovary. It also thickens the cervical mucus to prevent the sperm from joining the egg. It is not an abortion pill because it will not terminate an established pregnancy, nor if a woman was already pregnant, it would not cause harm to the developing fetus. And then, of course, abortion, which is the expulsion of the conceptus and can happen naturally or can be made to happen. So, abortions could be a spontaneous abortion, or it's also called a miscarriage. It's the death of a fetus before it can survive on its own. There could be physical trauma, problems with the conceptus, or problems with the physical conditions of the uterus that result in a spontaneous abortion or a miscarriage. And about one third of all abortions in the US are spontaneous. There are two methods for abortions. Early abortion methods differ obviously from late abortion methods. Medication abortion is abortion that's done through pills. And there are two pills, mifepristone and misoprostol. They're known in the US as Mifeprex or RU46. These block the activity of progesterone, which is the substance that helps sustain a pregnancy. And it's used to end an early pregnancy. So it has to be 70 days or less since a woman's last menstrual cycle began. So you can see here that the most abortions occur within 8 weeks of pregnancy or earlier. 89% of all abortions occur in the first 12 weeks. Other methods are the vacuum aspiration or suction abortion. The uterus is gently vacuumed, removing the conceptus, the placenta, and the endometrial tissue. And this is the method that's used for nearly all first trimester abortions. Then you have a D&E, which is dilation and evacuation. It's usually performed during the second trimester and can be performed beyond week 24. But as you can see from that chart below, very few women obtain later abortions. And so here we are, second trimester induced abortion. So this occurs in rare cases. Abortion is achieved by administering medications that cause the uterus to contract and expel the fetus and placenta. These generally occur when there is some major medical problem or illness in the pregnant woman or fetus. Another method is a hysterectomy. It's very rare again. It's performed in a manner similar to a cesarean, but in this case, the uterus and sometimes ovaries are also removed. And this can also be performed during late second trimester. When we look at the safety of abortion, so abortions performed in the first trimester pose virtually no long-term physical or psychological complications. In fact, having an abortion in the first trimester is safer than carrying the baby to term and giving birth. The single greatest factor influencing the safety of abortion is gestational age, so how old is mom, and early pregnancy is safest, so before 12 weeks. Almost all women will have some bleeding after the procedure, lasting from several days to several weeks. And sometimes there's transient feelings of loss, sadness, or stress, but they're often replaced with relief and satisfaction. And in fact, the number one feeling that most women who've had an abortion say they felt was just like a great sense of relief, like, okay, now this is over, let's move on. So currently abortion rates in the US are their lowest in 40 years, but it's a common experience among women in the United States. And three-fourths of women who have abortions cite these motives, that they were concerned or responsible for others and couldn't spend time worrying about another baby. They could not afford a child. Having a child would interfere with work, school, or the ability to care for dependents, or they didn't want to be a single parent, or were having problems with a husband or partner. Okay, this moves on to the next chapter 12, conception, pregnancy, and childbirth. So fertilization and fetal development. Once the oocyte, which is the egg, is released from the ovary, it drifts in that fallopian tube where it may be fertilized if a live sperm is present. So all pregnancies initially occur in the fallopian tube. If a pregnancy proceeds without interruption, the birth will occur in approximately 266 days, which is 10 months. So the oocyte remains viable for about 12 to 24 hours after it's released, and most sperm are viable for 12 to 48 hours. And so if you think about 48 hours, that would be you could have sex up to 4 days before ovulation occurs, and you could still get pregnant. So for fertilization to occur, intercourse must take place between 5 days before or 1 day after ovulation. Sperm that reach the oocyte are not yet capable of getting through its outer layers. There is a process for the sperm to get through, and it's called capacitation. So the sperm's membrane becomes fragile enough to release these enzymes, and the enzymes end up breaking through the wall of the egg. Once a single sperm is inside the oocyte cytoplasm, an electrical reaction occurs that blocks any other sperm. So once one sperm gets in, then um, think about gives like maybe electrical shock that the other sperm will fall off. And the oocyte becomes a mature ovum by forming the nucleus. Now, the ovum and sperm release their chromosomes, which combine to form a diploid zygote. And this contains 23 pairs of chromosomes. Fertilization is now complete. And now we have the development of the conceptus. So first is the blastocyte. So this is the zygote after a series of division over the course of about 4 to 5 days. The blastocyte is what implants itself into the uterine wall, and it's about 1 week after that fertilization occurs. It floats in the uterine cavity for a day or two, and then it'll implant itself in the soft, blood-rich uterine lining. And it's considered a blastocyst or pre-embryo, which starts rapidly growing into an embryo, which then in turn will be referred to as a fetus after the 8th week of pregnancy. The placenta is an organ that is formed during pregnancy, and it connects the fetus to the uterine wall. It provides the nutrients and oxygen from the mother's bloodstream to the fetus, and also removes waste products from the fetus's blood. It grows larger as the fetus grows, and attaches to the uterus and then to the fetus through the umbilical cord. And it also serves as a biochemical barrier, but there are certain prescriptions that can get through the fetus or through the placenta and to the fetus and also harm the fetus. And so some principal tasks of expectant parents as they progress through these stages. So for mothers, you begin to develop an emotional attachment to the fetus. You begin to differentiate yourself from the fetus. Acceptance and resolution of your own relationship with her own mother, resolution of dependency issues involved with parents or a husband or partner, and then just start evaluation from a practical and financial responsibility. For fathers, there's also a period of time where they have to learn to accept the pregnancy and attachment of the fetus. And by this, I mean emotional attachment to the fetus. Acceptance and resolution of the relationship with your own father, resolution of dependency issues, perhaps with your parents, the wife, your partner, and evaluation of your own practical and financial responsibilities. And there are also adjustments and psychological changes that occur in women during pregnancy. So during the first trimester, it may be the most difficult. Hormones are doubling every single day, and as a result, many women will experience morning sickness, which includes nausea and fatigue. Thankfully, during the second trimester, most of that disappears, and the woman can begin to feel the fetus move and may begin to feel radiant and beautiful, although she may be concerned about her increasing size. And by the third trimester, there are some challenges. There's edema, which is water retention. There's a lot of pressure on internal organs, such as lungs and bladder. Taking deep breaths may be difficult, having to urinate more often because the bladder is smaller. It's also quite quite frequent. And then just physical abilities become limited as your sense of balance begins to change and your uterus begins to grow very large. And so here you can see as the uterus grows, it's not like there is a place in the body for it. So as the uterus grows, it just pushes other organs out of the way. As you can see from the image here, there's pressure on the bladder, which is in the bottom. There's also pressure on the stomach, which pushes up towards the lungs. And pushes on the diaphragm of the lungs. So again, it makes filling those lungs completely more difficult because of pressure on the diaphragm. And then there could be some complications and dangers during pregnancy and dangers to the fetus. So there's teratogens, which are substances or other factors that can cause defects in developing embryos or fetuses. The greatest vulnerability, though, is during the embryonic stage, weeks 1 through 7, and early fetal development. So generally during the first trimester are also the most risky for the growing embryo. And the problem with that is, many women don't know they're pregnant, and so they haven't altered their behavior or may still be drinking alcohol or taking drugs, smoking marijuana, or taking marijuana, which can result in an impact on the embryo. So there is no known safe amount of alcohol consumption for women, although different doctors have different ideas what's considered safe. But when women drink too much alcohol while pregnant, it can harm the fetus. And so there are some conditions that can occur. Fetal alcohol syndrome, there's fetal alcohol spectrum disorder, alcohol-related neurodevelopmental disorder, alcohol-related birth defects. And so all of these result in some sort of damage to the fetus, although it depends on how much alcohol was consumed during pregnancy. But generally, if mom is drunk, that alcohol has also reached the embryo. There's also some other complications. Ectopic pregnancies are when the fertilized egg grows outside the uterus. It usually is in the fallopian tube. This is a deadly condition for mom. It will never result in a pregnancy that works. And the risk may be increased by PID, which is a pelvic inflammatory disease, or having previous ectopic pregnancies, treatment with assisted reproductive technology, and having endometriosis, which is growth of tissue outside the uterus. There's gestational hypertension or pregnancy-induced hypertension. And this is when a woman gets high blood pressure from being pregnant. This is coupled with edema, which is that water retention. This can be measured by looking at the protein presence in urine. And if this is untreated, it's very dangerous again for mom. It can lead to maternal convulsions and a stroke, leading to death. And then we have preterm births. These are births that take place before 37 weeks of gestation or of pregnancy, result in about 10% of all pregnancies in the US. The US actually has a pretty high rate of preterm births compared to other developed nations. One consequence of low birth weight infants, which is considered those who weigh less than 5.5 pounds at birth, is just infants that are not as healthy. 35% of infant deaths are associated with preterm birth related causes. And prenatal care is a really important means of preventing preterm births and premature babies. There are certain early methods to diagnose fetal abnormalities. And so these are prenatal tests to concern issues or concerns about birth defects. So there are carrier screening tests, which screen for parents' genetic information to see if maybe there is an increased risk of an inherited disorder, an example of cystic fibrosis. They can screen for risk of a birth defect, such as a neural tube defect, which is the basis that forms the spinal cord. Then there's also diagnostic tests. So there's chorionic villus sampling, where they sample cells from the placenta. There's also amniocentesis, where they withdraw some amniotic fluid. And then there's also neural tube defect screening, which is looking at the mother's blood to measure the level of alpha fetoprotein. So these are just two procedures to look to help diagnose a fetal abnormality. So on the left picture is amniocentesis. And so you can see they use a ultrasound to see the right placement. A needle is inserted through the abdomen, and they are pulling out some of the amniotic fluid and testing that to see if there are any abnormalities. And the picture on the right is a little similar, so you still use the ultrasound for placement, but this catheter is inserted through the vaginal canal, through the cervix, and this is where you are looking at again, pulling some material from the placenta to see if there are any abnormalities. So a pregnancy loss is the fetus before 20 weeks is called an early pregnancy loss. After 20 weeks, it's sometimes called a miscarriage or stillbirth. So miscarriage is the spontaneous expulsion of the fetus. A stillbirth is the death of a baby right before or during delivery. When you hear of infant mortality rates, these are the number of deaths of infants before their first birthday. And this is often used to measure a nation's well-being. Generally, the lower an infant mortality rate is, the healthier the nation is. Then you have sudden infant death syndrome, SIDS, which is an infant of less than 1 year dies of an unexplained cause. And obviously, there's feelings of shock and grief felt by those individuals whose child dies before or during birth. And it can also be really difficult for others to understand that grief or that sense of loss. On the other end of the spectrum, we have infertility, which is not being able to get pregnant after 12 months of regular unprotected sex. If a woman is 35 or older, it would be after 6 months of trying. It's equally likely to occur in both women and men. And the most common risk factors are advancing age, so being older, overweight or obesity, excessive alcohol use, smoking, and excessive stress. And fertility problems can really place a large burden on the couples and contribute to emotional stress. Coming to a joint decision about goals and accepting different therapies and an endpoint for therapy is important too. And what it means by an endpoint is at what point will you stop this method? About 12% of women aged 15 to 44 have difficulty getting pregnant or carrying a pregnancy to term. Age is the best predictor. So generally, the older a woman gets, the increased risk of infertility. As I said earlier, some other factors are smoking, excess alcohol use, poor diet, excessive athletic training, stress, being overweight or underweight, having STIs or health problems that cause hormonal changes. For males, it's about 9% of US men age 25 to 44 sought care for infertility. Sperm can also be altered by overall health and lifestyle. You can have a varicocele, which is a varicose vein on the testicle, low sperm count, decreased sperm motility, which is movement, poor sperm morphology, which is sperm that's misshapen, can often interfere with pregnancy. But other factors also include age, alcohol, tobacco use, drugs, STIs, and other health problems, such as mumps, kidney disease, hormone problems, and there are also certain medications and treatments that interfere with sperm production. And then some men are just born with problems that affect sperm. So fertility problems are almost always physical, and treatment can be very emotional and very expensive. There are some ways that fertility can be enhanced. So one is the timing of coitus or sex. So to look at the female cycle and to have sex on and around days of ovulation. For men, it's changing from tight underwear to boxer type underwear to allow the testicles to move more freely and to better manage the temperature. Many couples, however, may seek medical intervention to diagnose and treat infertility. However, prior to investing in those treatment options, it will often be recommended to engage in some preventative steps. So avoid alcohol, avoid tobacco and drugs, exercising and eating a healthy diet. There are other interventions that can be sought after if wanting to promote conception, which is pregnancy. There are medications, there are surgeries, there's artificial insemination. So it would be healthy sperm, introducing healthy sperm into the woman's uterus. Assisted reproductive technology, which are called ARTs, are all treatments in which both eggs and sperm are handled. There's in vitro fertilization, where eggs are fertilized in a laboratory and then placed in the woman's uterus. There's intracytoplasmic sperm injection, where a single sperm is injected into a mature egg, and then again, those are placed into the uterus. ARTs are often associated with high rates of multiple births because they will often fertilize multiple eggs and then place all fertilized eggs in the uterus, hoping that one or two stick. There are other options, such as having a surrogate mother, where another woman would carry a fertilized egg for the couple. A gestational carrier is a woman's own egg is fertilized by the man's sperm and then placed inside a carrier's uterus. And for both of these, age is still an important factor. Then we have the last part, which is giving birth. So during the later months of pregnancy, the placenta produces the hormone relaxin, and this increases the flexibility in the ligaments and joints in the pelvic area. Before birth, there's something called Braxton Hicks contractions. It's a strong uterine contraction that exercises the uterus and prepares it for labor. These are also called false labor. Now, during labor and delivery, it's divided into 3 stages. So true labor begins when the uterus contractions are regularly spaced. There's effacement, which is a thinning of the cervix, and dilation, which is the gradual opening of the cervix. And the fetus presents itself into the vagina. So it takes about 2 to 36 hours for the fetus to start moving into the vaginal canal. The first stage of labor starts with the expulsion of the mucus plug that has blocked the cervix. And so this is what you would think of a mucus, snotty material that has been blocking the cervix, and it's expelled from the vagina. Then there's transition, where contractions become more quickly, they're more intense, and the baby's head begins to enter the birth canal. The second stage of labor is when the baby's head moves into the birth canal, which is the vagina, and to when the baby's born. Generally pretty short. When the baby's head begins to merge and not slip back in, this is known as crowning. So after delivery, the baby is still attached to the umbilical cord, which is connected in the mother to the placenta. It will not be cut until it stops pulsating. So they will wait until the umbilical cord stops pulsating, which indicates now it is not delivering the nutrients to the baby. There's something called vernix, and this is a waxy substance that covers the baby, makes the baby slippery to make its way through the birth canal. And then the third stage of birth is the afterbirth, when the uterus continues to contract and it expels the placenta and the remaining section of the umbilical cord and the fetal membranes. The attendants will assess the condition of the neonate, which is the newborn rating, heart rate, respiration, skin color, reflexes, and muscle tone. They use a system called an APGAR score. It's between 0 to 10. They do it right after birth and then an hour into after that. And it just helps assess quickly if the newborn needs any additional medical interventions. The mother will continue to feel contractions and will have bloody discharge called lochia after giving birth. And there are choices in childbirth. One is elective delivery. You perform a cesarean for non-medical reason. It could also be taking drugs to induce labor, but most professionals will agree the best labor plan is to wait for the delivery to begin on its own. And then you have cesarean section or C-section, which is delivery through an incision in the mother's abdominal wall and uterus. And there are many medical reasons for having cesarean. It could be abnormalities of the placenta, umbilical cord, or having a prolonged or ineffective labor. Subsequent deliveries will not need cesareans just because the previous one was, but generally the more cesareans you have, the more likely is your next birth will be a cesarean. And then there's prepared childbirth. And this is just based on learning about conditioned reflexes. They'll cover breathing exercises, other exercises. Often prepared childbirth classes occur in the hospital. You'll get a tour of the delivery and labor room, a tour of the maternity centers. It could also be a home birth where you do it at home, or you elect to have a midwife who may be a registered nurse, a doula, which offers emotional support and helps manage the pain. And then after birth, there is the choice to breastfeed, which is the ideal food for babies. Because it contains the right amount of nutrients, it helps boost the baby's immune system, and it's just one of the best ways to keep the baby healthy. So lactation is the production of milk. It usually begins about 3 days after childbirth. Prior to the 3 days, right after birth, liquid is produced in the breast. It's called colostrum. It's a yellowish liquid. It's a little clear. It's secreted by the nipple to help nourish the newborn before the mother's milk comes in. And it has a lot of protein and antibodies that really help protect the baby from getting sick. And then postpartum and beyond. So after birth, postpartum period is considered 3 months or so following a childbirth. And it's a time of physical stabilization, emotional adjustment, as you can imagine now having a newborn. As a result, we have a Family and Medical Leave Act, FMLA, and it assures that the US women and males are eligible for employees for up to 12 months of unpaid job protected leave for a specified family and medical reason with continuation of group health insurance. So you will get months, unpaid months off of work without the fear of having to lose your job with continued health insurance. But there are also maternity leaves for in many companies, which are separate policies where they will pay for maternity leave. Many mothers may experience the baby blues with irregular sleep patterns and feeling of isolation from their family, from their familiar world. And a father's involvement in their child's life have been shown to have a really positive effect on the child's well-being. And this is not just for the postpartum period for the child, but also through the entire life. And then there's postpartum depression, which is moderate to severe depression in a woman after she has given birth. It is thought to be related to the hormonal changes brought on by sleep deprivation, weaning, and the resumption of the menstrual cycle. During this time, anxiety disorders may arise or recur. And then, even more dangerous is postpartum psychosis, which is way more serious than depression. It's thought to be exclusively biologically based and related to hormonal changes, which is sometimes good news when it's exclusively biologically based, meaning that medication um, is really beneficial in reducing the symptoms of postpartum psychosis. So, regardless if a woman has experienced depression or psychosis, it's really important to talk to her doctor, uh, go to a clinic, because these are treatable disorders. They occur pretty regularly in women after they give birth, and it's something that can be treated effectively. So it's important if you or somebody you know is experiencing it to get them to talk to someone so that they can get treatment. That ends our PowerPoint for this week. Have a wonderful week, and of course, let me know if you have any questions or concerns.